Good evening. I'm Lou Goldstein, and welcome to part 2 of my conversation with Dr. Shefali Patel. We're talking about women's health issues, and we had a very interesting conversation in part 1, and tonight we'll be continuing our conversation about important women's health issues, from adolescence through menopause and beyond. For those of you who are joining us and did not hear Dr. Shefali Patel's background, let me tell you a little bit about her. She's a much sought after board certified OBGYN who has an office in Westfield, New Jersey. Her practice focuses on providing expert care in birth control, HPV management, menopause management, fibroids, minimally invasive surgery, and the treatment of endometriosis. Her practice also is equipped to offer in-office ultrasound, colposcopies, and biopsies, and they also offer medical cosmetics including Botox, fillers, and Latisse. She completed her undergraduate studies at City University of New York and earned her medical degree from Mount Sinai School of Medicine, followed by an internship and residency also at Mount Sinai. She is in much demand. She's been praised by her patients not only for her superb medical skill, but also for her compassion and sensitivity. And it's an important conversation today, both for men and women, because these are health issues, and we're looking at, preventing, disease, and also making sure you take care of yourself and go see the doctor now that we're getting to the end of the pandemic. And it's important that we make our appointments on a regular basis so that we make sure our bodies are tuned the right way. So first of all, thank you very much for staying with me, to have part 2 of this conversation. And we covered a lot about adolescence in the beginning of our show. And I'd like to start off more towards, menopause, getting more toward menopause right now. But before we do that, a lot of times people who've been trying to have babies have difficult, getting pregnant. Mm-hmm. And one of the questions that we receive is, I've been trying to have a baby and nothing is happening. When should I see a doctor?
Mm-hmm. That's a good question. So usually we say between 6 months and a year of trying to conceive, if there's no success, to come in. So when you come in, we get a little bit of a history of how long you've been trying, how often you're being intimate with your partner, what your cycles are like, trying to get a sense of whether your periods are regular, you're ovulating regularly, and then we try to do a basic workup. So that's usually doing some blood work on our female patients, checking their hormones, checking what we call the ovarian reserve. So you have a certain amount of eggs from the day that you're born, right, and that quality and quantity of eggs starts to go down as you get older. So we can check to see how that's looking by doing some blood tests. And then on our female patients, we also do a pelvic ultrasound to just make sure that, again, structurally the uterus looks normal, that there aren't any polyps, fibroids, cysts, things like that. And then we do something called an HSG, which is a little bit more of an invasive test, but basically it's done with the radiologist, and it puts a little dye into the uterus to make sure that the cavity inside the uterus is normal to be able to hold the baby, and that the fallopian tubes are open to be able to take that egg from the ovaries and bring it into the uterus. And then on her male partner, he would have a semen analysis to just make sure that his sperm is good, that there's a good amount of the sperm count, and the sperm's healthy, that kind of thing. And then after that, we can talk about some basic fertility medications to help somebody to ovulate more regularly, to be able to, try and help them conceive with a little bit of help. And if all of that doesn't work, then we send them off to the reproductive endocrinologist to talk about, more invasive things that can be done. But we've made great strides in reproductive medicine now, where we can really help somebody have a baby with maybe just a little bit of help, or maybe even a little bit more, if that's needed.
Okay. So I think one of the things that, for some reason there's been an increasing number of women who are having, and men, who are couples that are having trouble getting pregnant. And I know it's a very frustrating feeling sometimes, mm-hmm, but I know that those rooms are starting to fill up and they're getting bigger. And sometimes also because now a lot of individuals want to choose the sex of their child. Maybe they have 2 boys, mm-hmm, and they want to have a girl. And that's the far end of it. Mm-hmm. But I'm just saying it's a very growing field. And I'm wondering if you're seeing an increase in patients coming to you, with those concerns.
Well, I think one of the biggest reasons that in general we're seeing a little bit more of the infertility issue, or I'm seeing patients, is that a lot of women are kind of waiting a little bit longer now. Like, a lot of women are in school or in their careers are waiting. If I see somebody now in their 20s who's having a baby, it's very unusual. Like almost all of my patients are in their 30s, mid-30s, and a lot of times patients aren't starting, to even think about having children till their mid to late 30s, where sometimes, that ovarian reserve, the quality and quantity of eggs, things like that can start to diminish a little bit, and, they may need a little extra help or a little extra guidance of, even when to try, or, other medications, things like that. So and then we can also now, choosing the sex of your child is one thing that is, maybe IVF is being used for, but more importantly, if you have any kind of inherited disease in your family, if you're a carrier of a certain mutation, or somebody else in your family is, and you don't want to pass this on to your child, this can be done with pre-implantational genetic testing. So there definitely are such great strides being made, and in being able to help patients to start a family, and also to be able to minimize some of the known diseases that we know can be passed on genetically. So there's definitely a lot of patients that are benefiting from this advance in medical technology.
Okay. Well, let's go to the far end of the spectrum now. Let's talk a little bit about menopause. And how do women know that they're starting menopause, and how long does it usually last, and how do women know that it's over?
So menopause is really actually a retrospective diagnosis. It's 1 year of not having a period. So that's when you officially are menopausal. So it's 1 full year of no period. The average age is 47 to 52.
Okay.
But that being said, some of the perimenopausal changes can start like sometimes 5 to 10 years beforehand. So a lot of times women will start to feel some changes when they hit their 40s. And you're not really prepared for it, because you're like, well, menopause, that happens like when you're 50 or in your 50s. What is going on with me now? But, the menopause happens when your ovaries stop working, and like they stop producing the eggs. So they're just, kind of peter out. It doesn't happen overnight, it happens over a span of time. And then, so they kind of slow down, they don't work as well, then they might work really well for a while. It's almost like a light bulb that's flickering, right? Like it kind of comes and goes. Sometimes it shines really brightly, and sometimes it's, flickering. So your ovaries are kind of doing the same thing. And during that time, you can feel a lot of different things. You can start to feel some, hormonal changes that can cause some moodiness, irritability, anxiety, phobias, like all these things that women don't even associate necessarily with their hormones or with menopause. You can start to have menstrual irregularities, heavier bleeding, lighter bleeding, skipping cycles coming closer together. All of those things can happen. Acne, breast tenderness, almost feeling like you're a teenager again because, things are going a little haywire. So all of these things can be leading up to menopause, can be normal. Some women experience all of them. Some women experience none of them. It's very individualized, and there's really no great way of predicting like what your experience is really going to be. It really is sort of, as it comes up, and then often retrospectively being like, oh, I guess that's what was going on, Do
you find that a lot of women go through, the hot flashes, and, that's part of menopause, and that's normal?
So like the main things that we think of are the vasomotor symptoms. So hot flashes, night sweats, insomnia are ones that our patients, often think of, right? So they're like, oh, I'm experiencing this. I must be experiencing menopause or perimenopausal changes. And it's true. Those are some of the common ones. Those are some of the ones that are the most bothersome. If you're a lawyer, if you're a teacher, and all of a sudden you're having a hot flash and you're red and you're sweating and you're still trying to go about your business, it's very, very hard. So some of those patients will come in and be like, what is going on with me? Not sleeping. Sleep is huge, and it's restorative. And if you're waking up with hot flashes or night sweats every couple of hours, where you're sweating, you're drenched, you have to change your clothes, you're hot, you're cold, you're not getting a good night's rest, right? Which then affects everything else, affects how you eat, how you exercise, your mood, your energy, all of that other stuff. And a lot of times, this is also all happening to women at kind of like the perfect storm in their life, right? Often you have teenage kids by the time that you're in your late 40s and your 50s. You have aging parents that you might be helping to take care of. you're sort of in the height and peak of your career by this point, right? You've been working for a while, and so you have those demands. You're in a relationship, whether it's marriage, boyfriend, whatever, that might also need some, attention or work.
Right.
And then your hormones are going crazy. So often you can feel like overwhelmed. You can feel like you're also going crazy because, like we talked about, certain phobias can be heightened, certain anxieties, irritabilities. Like I just gave a talk on menopause a few months ago, and 3 people, an audience of 40, said that they had to pull over on the side of the road when they were driving home and literally thought they were having a heart attack. And
wow.
Ambulance came, took them to the hospital, and it was a panic attack. And they've never had one. One of them is a social worker, deals with this, helps people through panic attacks. And after a full cardiac workup and everything, they were like, I think you were having a panic attack. And sometimes it's not even recognized by the ER doctor or even the cardiologist, because obviously you want to make sure you're not having a heart attack. But then, why is this happening to you?
Right.
So there are these subtle changes that sometimes you don't even put together. So if you are feeling any of these things, it might be worth a conversation. There are things that we can try to help you with, from sort of behavioral, lifestyle management to medications to hormones. There's a huge spectrum of what is available. So it may be worth, seeking out help if you're feeling any of these things, because I think the take-home message for me really is to tell women that it is a very normal part of life, but it it can be hard to get through, and you should definitely talk to your doctor to see if there are things that they can help you with.
Okay. A lot of times women develop fibroids, right? But they're concerned, they don't want to have a hysterectomy. Is there anything else that they can do to address this?
Mm-hmm. We've made, again, in that field also huge strides in minimally invasive surgery and minimally invasive management, not just surgery, but medication-wise. So for fibroids, depending on where they are, some of them need surgery and there's no way to avoid that, which could be a myomectomy or just removing the fibroid, or a hysterectomy, removing the whole uterus, depending on where they are, how big they are, where you are reproductively. That's a conversation to have with your doctor, but those are more the surgical things. But there's medications out there now that can be taken orally that can help to shrink the fibroids and to stop the periods. There is something called hysteroscopic myomectomy. So if the fibroid is inside the cavity, we can do the surgery all through the vagina, go into the uterus, and just shave off the parts of the fibroid that are causing the heavy periods. Okay. Go home the same day, no incisions, no cuts, nothing like that. There's robotic surgery. So there are a lot of things that can be done. Again, it can't be, has to be individualized to, each woman and how big her fibroids are, where they are, how symptomatic she is, but definitely there's a lot to do.
One of the things we did cover last time, I think it's worth repeating, is talking about HPV. And can you talk a little bit about HPV, both as it affects men and women, and the connection with cervical cancer?
So HPV stands for human papillomavirus, and it is the most common sexually transmitted infection, or STI, out there. About 60% of women will be exposed to it. Men are generally just carriers for the high-risk HPV, so there's no necessarily ramification for them for the high-risk strain. Right. So there's the high risk and the low risk. The high risk causes cervical cancer, and the low risk causes genital warts. So the genital warts can affect everyone equally. So men and women can both be affected by this. And if you don't have HPV, you are unlikely, it's almost zero, to develop cervical cancer. So cervical cancer is completely caused by HPV. That being said, only 3 to 5% of women with HPV will ever go on to develop any kind of high-grade dysplasia or cervical cancer. Okay. With good gynecologic care, cervical cancer is very preventable because the changes that come along with HPV are reversible. So it's a little unusual in terms of when we think about cancer. Let's say they saw something in your breast, we would never say, hey, let's watch it for 6 months and see if it goes away, right? Because it's only going to continue to grow. With HPV, as it's more active and it causes damage to the cervix, we pick up abnormal pap smears or dysplasia or precancerous lesions that we can manage, watch. And often when your body fights off this virus and it goes dormant or it goes clear, those changes are reversible and you go back to normal. So it's very unusual. It's a little confusing sometimes for patients to understand, but there is a lot that we can do to watch and surveil and prevent somebody from ever going from normal to cervical cancer. And there are things that we can do in between to make sure that you never get to that point. Okay.
I know we talked a lot about parents bringing their daughters in and maybe we could reinforce, a good age. What's a good age to start that?
So unless there's any major issues, and oftentimes some of the early issues that come up when you first get your period are often managed by the pediatricians. If the pediatrician doesn't feel like they can, or it's out of their scope, they will refer to us.
Okay.
If your daughter is, you think dating someone seriously or thinking about being sexually active, that might be a good time for you to also bring her in. If none of that is going on, I usually say, the senior year of high school, just to kind of have a general checkup, a breast check. We don't have to do a pelvic exam. We don't have to do anything invasive, but just to talk to her about what's going on, how are her periods, are they painful, are they heavy, what's considered to be normal, normal discharge, to also have that same conversation about safe sex, contraception, emergency contraception. And I really try to highlight to my teenage patients that, this is their one body, they have one chance to do it right, that they always have to be respectful and always make good choices, for themselves, that, there are things that they can have that will last a lifetime. All of the viral infections and STIs, there's no treatments for. So if you have herpes or you have HPV, it's going to be with you forever. So safe sex prevention is really something that I try to stress to all of my younger patients. We don't start pap smears until patients are 21, but I think for all these other things, coming in a little bit earlier can be very helpful.
Okay. One of the things I want to talk to you about is that I noticed that you offer also the beauty cosmetics in your office of, Botox and fillers and Latisse, so maybe you can explain that and the benefits or the fact that you do offer them.
Yeah, definitely. So for me, I often see my patients getting older with me. I may have operated on them, I may have delivered their children, and a lot of them are the same age that I am, and we've been together for 15, 16, 17 years sometimes. And some of the changes that start to happen in terms of little fine lines and wrinkles, or as we age, we kind of lose, some of what is the normal aesthetic, the high cheekbones, the tapered chin, and the fillers can help with that. So Botox can basically be used above the eye and above. So anytime that you see wrinkles, anything where you feel like you can do this, that's what Botox is going to help you do. It's going to not allow you to move that muscle. You're going to look a little softer, a little more rested. Your eyes will look a little bit more, alive and alert. And then the fillers help you get back a little bit of volume. If you're starting to see these lines here, you're feeling like your cheeks are, looking hollow, then you can get back a little bit more of that volume, and that's through something called hyaluronic acid. So both of them, Botox lasts for about 3 to 4 months. It's done in the office. It's a quick, 15 to 20 minute appointment. The fillers usually last 12 to 15 months, some of them a little bit longer. You can also, if you feel like you're losing some of the volume and fullness in your lips, you can use fillers for that too. Again, a quick 20 to 30 minute appointment with very minimal downtime. A lot of patients come in and go to work. A lot of patients, are doing it at their lunch hour. So it can definitely be a quick outpatient little pick-me-up, to make you feel a little bit more rested, refreshed, rejuvenated. We can do Latisse for eyelashes. That's something you can just do at home. It was a medication that was developed for glaucoma, and then they saw these patients in their 70s and 80s with these beautiful eyelashes, and they got the patent for it. So it keeps your eyelashes in the growth phase that they're longer and more lush. You can use them for your eyebrows if your eyebrows are thinning too. So these are all things that are pretty minimally invasive, but can really make you feel more confident, can make you feel, just better about yourself. Which there's nothing wrong with, right? Yeah.
Nothing wrong with self-care. No, absolutely not. So I know that over the course of your life, I'm sure you've had individuals who have been influential for you. And one of the things I'd like to ask all my guests is if you could just discuss somebody who was influential in your life to getting to where you are right now, or who has been served as a role model for you. Who would that be?
I think that one of my teachers that probably had the biggest impact on my education and sort of direction of my life was probably Mrs. Stein, who was a 4th grade teacher. I grew up in Queens. I'm a first-generation American. I was the first one born here. My parents immigrated here in 1972. So my dad was a professor in India, so he had some idea of how the Indian education system worked, but not as much here.
Right.
And I think she saw my interest in medicine, my interest in science. I was in the gifted and talented program with her, and she really helped my parents to kind of help us pick out a more specialized high school. So I went to one of the, equivalent magnet high schools in Queens. And I think her interest in my education and sort of picking up on my interests and helping them to guide through this process that they weren't familiar with, I think kind of set the trajectory from high school. Then I went to straight combined 7-year med program right out of high school, where I was guaranteed to get into medical school. And I don't know if I would have had all those opportunities if she hadn't kind of helped to guide. And she was just such a selfless, loving teacher that I still remember her all these years later.
Wow. So do you think that if you weren't a doctor, you'd be a scientist?
You know what? It's so funny because when I was younger, I wanted to basically be a pastry chef or be a hairstylist. And it's so funny that I think that now because I don't know how to do anything with my hair other than just wash it and go. But I still like to bake. So I don't know. I feel like part of me thinks that I might have done something a little bit more, along those lines. Like I still want to own
a B&B.
Yeah, when I retire. So I think maybe something in cooking or in baking or something a little bit, completely unrelated to the sciences.
That's
maybe
the next chapter, I guess. Huh?
Maybe.
Maybe. But just getting back to this, when we talked a little bit about the importance of making regular checkups, did you find during the pandemic, that people put off their appointments, with you, women put off their appointments with you, and now they're coming back and making those appointments on a regular basis?
So I kind of saw two big things. One was the first couple of months we were all in shutdown. Only patients that we were seeing were emergent patients. But when things kind of opened back up in that summer of 2020, a lot more patients started coming in, like patients who hadn't been in 2 or 3 years. And I think the reasons for that were coming to the gynecologist felt safe. Like we weren't really treating patients for COVID. I don't think they felt nervous that they were going to get it in my office. But I think that they were working from home. Often their spouses were working from home. They had childcare. They didn't have to worry about making an appointment, coming from work, on the one evening appointment that we have. And I think people wanted to take better care of themselves. I think that this was a wake-up call, what happened in the pandemic to a lot of people. Like I've put my health, on the back burner. And then now I'm still seeing some patients who really didn't see doctors for a couple of years. So now I'm seeing like that next wave that finally feels comfortable to come in. So there were women that were like early adapters who were like, I got to get in, I got to take better care of myself, and started that process in the pandemic, eating healthier, exercising, walking, having more free time now, especially because a lot of people are doing some sort of hybrid schedule or working from home. I think it's really helped a lot of working women and working moms to take like you said, self-care and a little bit better care of themselves. They got like 2 or 3 hours back from their commute.
Right.
But there was definitely a decrease. There was definitely a decrease in preventative screening. A lot of women, did not go for mammograms, did not go for colonoscopies. So we definitely saw like an uptick in certain types of preventable cancers and things like that. But I think for me in general and in my practice, we've been so busy since probably that June or July of 2020, because I think a lot of patients are being a little bit more proactive about their self-care.
Right. Have you seen a lot of patients saying that basically because of the pandemic, they've changed the way they've lived and how they're going to, basically take care of themselves? Yeah,
and I think that one of the benefits from that is sort of this a little bit more of a flexible schedule, being able to work from home. Like a lot more of my patients are now taking that time and exercising, even if it's going for a walk, cooking more, because they can. Like even if they're going back to the office now, nobody's going back really 5 days a week.
No.
So even if they're going back 2 or 3 days, they have that flexibility the other days that they're at home to really be able to set themselves up to really, decrease their stress, to maybe increase their exercise, eat a little healthier. I definitely feel like a lot of patients have adopted that.
That's great. Well, certainly enjoyed our conversation. We covered a lot of topics over the
Always
2
a
interviews, and everything from adolescence through menopause. And now your office is in Westfield. Why did you pick Westfield?
So actually, this is the furthest I've ever moved from New York City. I grew up in New York City. I went to undergrad, med school, residency, everything in New York City, and then took a job in northern New Jersey and kind of picked Cranford randomly to live in.
Okay.
And when I stopped doing OB, when my second child was born, I wanted to have a practice a little bit closer to home.
Okay.
And that's how I found my spot in Westfield.
Nice.
Yep.
Nice. Well, it's a good place. Cranford's a good place too.
Yep.
And I wish you and your family good health and your practice much success in the years to come.
Thank you.
Well, thank you very much. That's Dr. Shefali Patel. You can find her. Do you have like a website?
Yes. So it's just my name. So it's www.drdrshefalipatel.com.
Great. So I know that Dr. Patel is a most sought after physician for women's health care. So if you have any healthcare issues, please seek out Dr. Patel. She'll give you good advice and she'll set you on the right path. And so I'd like to thank her, and I'd like to thank everybody else associated with the show as we wrapped up these 2 interviews. And I hope that everybody enjoys the upcoming holidays, and look forward to seeing everybody in the new year as we continue our interviews on Focus On. So until then, I'm Lou Goldstein. Thanking you for watching. Have a good night. Stay healthy, stay active, and stay focused. Have a great night.